somehow stay on time, I think we're just going to open the session. This is the session on neuromonitoring. I want to welcome everybody here. It's really a full house. And I'm going to hand it over to my friend Mauro, and he's going to introduce our first speaker.
Yes, hello everyone. Mauro from Lausanne, Switzerland. So the first speaker today about this neuromonitoring session is Giuseppe Citerio, who is a professor of anesthesia and critical care in Monza in Italy, and he will talk about pupil reactivity, the simplest method.
Thank you very much, Mauro. And if I can have my slide. Okay, we will talk about pupillary reactivity today. It's a very simple things we can implement at bedside, but I think we can have a lot of information. I will present the result from a trial that has been sponsored by Neuroptics, and I don't have any commercial interest in it, but the trial has been sponsored by a company. So I would like to discuss about pupillary reactivity, and I will give you a short background. Then I will present you the study we just finished on pupillometry, and we will discuss the preliminary result, the implication of the preliminary result of this trial. Looking at the background, today you will hear about a lot of technology we can apply bedside. The pupillary reflex is very simple, 3 neurons. And as you can see from this color, we can have some interference by opioids, by the light green, high intracranial pressure compressing the brainstem of the third cranial nerve. And also you can have effect of pain. So it could be a reflex that you can obtain easily at the bedside, but could be affected by many factors. And we will focus today mainly on outcome and intracranial pressure on this reflex. And the way we did it since the birth of intensive care is to use a light pen, and a nurse was doing it at the bedside. What we discover over time is that the error in this test done by the nurses, not in a standardized way, is very common. And the nurse make error in size of a pupil, reactivity of a pupil, and this error, for example, for reactivity, could soon be summarized as 18% of the time. So the error, due to the confounders we discussed earlier, also the fact that the light the nurses were using was not standardized, had a lot of associated errors. So on the market, 2 devices come because the technology with a standardized, very high intensity light on the retina of the patient will produce the reaction of the pupils, but we can record many parameters that the nurses could not record. The exact baseline pupillary diameter, the velocity of constriction, the maximal constriction of the pupil, and the escape of the pupil afterwards. This element could not be integrated in the clinical evaluation by nurses, but both the devices give you some information about the size, the latency, the constriction velocity, and the dilatation velocity. Putting together this element, one of the 2 devices, and we'll discuss only one of the 2 devices, present also an index, the so-called MPI, that take in account all these elements. And the curve you see here is the curve reproduced by the machine. So you do the same test I presented to you earlier. But at the end, all the parameters are put together in an index that is an indication how far is the reactivity of your patient far away from normality. And the index goes from 1 to 5. In a recent paper on intensive care with Fabio Oddo and Claudio Sandroni, we summarized some concept on pupillometry, and we say that we are trying to avoid at the bedside a new onset of dilated fixed pupil because it's an alarm, it's the compression of the brainstem. And some study coming, for example, from Mauro Oddo group, demonstrate that MPI changes anticipate the clinical deterioration and are associated with sustained episode of elevated ICP. And when the doctor was able to reduce ICP, the pupil returned back and MPI returned back to normality. And we conclude that we need some prospective study in this setting because we have a tool, we have a reflex, we have a possibility to test it bedside. And so we developed the so-called ORANGE study, and is the acronym of the outcome prognostication of acute brain injury with the neurological pupil index. It's a prospective observational study because we didn't change the practice in the clinical unit, multi-center, international, and is sponsored by our university with an unrestricted grant by the company that didn't have any influence on the result of the trial. I was the leading investigator along with Mauro and Fabio Taccone, and we developed the structure of the data analysis statistician in Monza. We published the protocol before starting the trial, and we registered the trial. And the primary aim is to understand if we are able in 3 different pathologies, TBI, SIH, intracerebral hemorrhage, to find an association with abnormal MPI and outcome of the patient. And the secondary aim that we will not present today is to explore the relationship between ICP and MPI. And we enroll patients admitted to intensive care unit, not able to obey order, age 18 or older, and having a pupillometry as standard evaluation tool. And we avoid patients with direct facial trauma that don't allow pupils evaluation. We calculate the sample size with a statistician, and we were thinking to enroll more than 400 patients, and you will see that we got very higher compared to 400. We reached more than 500 patients in this study because the center has been enthusiastic to enroll even during the COVID pandemic period, because we target neuro units that were working with neuro patients even in that period. And so these are the preliminary results. We enrolled 514 patients in different centers. The size of the bubble is the number of patients for each center. And so we collected all over Europe and USA some data, clinical data and pupillometry data. The mean age is 61 years, and the motor score is distributed in all the categories. 34% were not moving, having no response on the Glasgow motor score, and most of the patients have a normal reactive pupil at the entrance of the unit. I think this slide summarizes a lot of information. We did collect pupillometry every 4 hours, so 6 times in a day in all the centers in a standardized way. And I think this is the main difference compared to other study that has been retrospective. And this is the distribution of the MPI, 30,000 MPI, but we worked on the worst side, so we use around 20,000 pupillometry data for our analysis. And this is the first result, and I will show you also some sequential analysis after this one. As you can see, the distribution on MPI have a normality. The Glasgow 5 to 8 Glasgow outcome scale is people returning back to autonomy. Then we have people disabled after trauma, SIH or intracerebral hemorrhage, and we have that here. And you can see here that the distribution of the curve is a little bit different, with a lot of zero number in this area with patients with a worse and negative outcome. But we went further because we wanted to understand which is the effect of having an MPI increase of 1 point, and you have to look at this result of these 2 slides as an hazard ratio compared to normality. So compared to the patient that didn't move, MPI going up is a reduction of 45% of negative outcome mortality in this case. Being over or below or over the classical threshold of 3, that is the pathological MPI, and if you return back, you can see that most of the number are over 3, but around 15% of the observation are below 3. And as you can see, being over or below 3, the hazard ratio becomes much higher. and staying to zero only once, you have a very high hazard compared to remain over zero. Each patient could move in this situation many times during his clinical life. So when you go to zero, you have a risk, but if you return back, what is the effect? And we explore this condition, because if we have a patient in 2 consecutive observations, we are working on trajectory, we are using now artificial intelligence, spline, plot, and other things for doing an advanced statistic. You can see that if you stay twice at zero, you have a certain risk, very high. The hazard is around 14. If you are able to recover from this situation because the doctor is infusing mannitol or is doing surgery, is doing something else, your risk return back near to normality. If you stay there for if you fall down from an higher than zero to zero, your increase of risk is important. And on the other point, we look at in another model, being below 3 is important, or being below 3, between 3 and 4. And as you can see, we have a risk going below 3, but also the hazard is higher if you stay between 3 and 4, not close to 5. So at the end of the day, we were able to demonstrate that the outcome is connected to pupillometry, and the dynamics of the exam we are doing, so you can go to zero, remain to zero, or return back over zero, or you fall down to zero. All this movement we are analyzing with, let's say, a more advanced statistical approach now, are associated with worse outcome in this population. And so we also explore, and I don't present you the negative outcome, not only mortality, and there is a strong association with pupillometry result and negative outcome, let's say a Glasgow outcome scale of non-autonomy below 4. So the conclusion of this talk is that we will discuss today a lot about different monitoring systems. The pupils are accessible to all the patients. We don't have to insert any probe. And we are used to do it with a standard light, probably using a device that could help you in having a better prognostic evaluation. For presenting you what is happening now, we are going to try to develop individual probability trend, building up a prediction model that update every time we make an evaluation with a pupillometry. So probably we are discussing of integrating this kind of information in the tool, because the tool is simple, give you some numbers, but the numbers, as you saw, are dynamic. When you go down, there is a risk. If you return back, the risk is less. But you, in your clinical mind, you have to put together all this information over the course of the disease, over the week or 2 weeks the patient stay in your unit. And probably also the eyes could give you some dynamics of improvement of a patient, and we will explore further in this first part of this year the relationship with ICP, trying to demonstrate and to validate the data, the early data from Meyfroidt group about the impact of IICP on pupillary reactivity, because if we are able to anticipate the increase of ICP somehow, could be also useful for identifying this setting of patient. Thank you very much for your attention.
Thank you, Giuseppe, for this excellent talk. Questions from the audience. So we're going to have questions after each talk, and I will ask the speakers to stay in time for this. So maybe, Jan, you have a question?
Yeah, maybe I'll start the discussion with one question. Really great presentation and great study. One thought, when I think about these diseases, right, SAH, ICH, and TBI, it's often a mixture of focal and diffuse injury, right, patterns. You can have hemorrhages, focal hemorrhages, and then you have IVH or, diffuse patterns. Did you also look at for example, if people have asymmetric pupil or pupillometer findings. So you can think of like uncal herniation, for example, causing a unilateral effect on the pupil. There might be additional data in there as well.
Yeah, there are thousands of additional data because, for example, 0, we are starting to explore the 0 number. 0 means that the pupil, the machine is not able to understand any movement from the machine, from the pupil, but there are pupils that are small size and pupils of a larger size. So we are going in deeper detail further, but I wanted to present you today only the early finding of the trial that did finish November last year. And the analysis is still ongoing, but I think we are taking also a look at the midline shift of these 500 patients, the different pathologies, the relationship with ICP, so many other stuff could be explored with pupillometry. It seem to be simple, but at the end of the day, even if the reflex is simple, the confounders are many, and we need to have some wisdom at the bedside from a device, so the device that could help us in tailoring the treatment and to anticipate deterioration and to give you some prognostic information if available.
All right. Thank you, Giuseppe. We move to the next speaker.
So our next speaker is David Menon. He is professor of anesthesiology and chair of the Department of Anesthesiology at Cambridge. And he's going to talk about biomarkers. David?
Thanks, Jan. Thanks, Mauro. And thanks to the organizers for inviting me to speak. I'm going to be presenting quite a lot of data from the Center TBI study, and I'll acknowledge that at the end. So the first theme I wanted to address was the basic biology and the background to the study. And there's a whole raft of protein biomarkers that have now been looked at in traumatic brain injury. There are other non-protein biomarkers, microRNA, metabolomics, and so on. But because of limitations of time, I won't address that. I'll just confine myself to protein biomarkers. Some of these are biomarkers that we've known for some time. For example, neuron-specific enolase and S100B. Both have been used to prognosticate and also manage TBI and cardiac arrest for that matter. But the newer ones are UCHL1, which is primarily, you'll see from the graphic here, a neuronal body biomarker. S100B is a glial marker. NFL, NFH, and neurofilament light and heavy are probably axonal markers. Tau, axonal and dendritic marker, and GFAP is another astrocyte marker. So there is a promise based on this of some specificity to cell body types and potentially for types of injury as well. So the context in which I'm going to describe our results is within the Center TBI study. This was a prospective multicenter longitudinal cohort study, involved about 4,500 patients, collected in 3 strata, with over 2,000 of them being in the ICU. Inclusion criteria were a suspicion of TBI and an indication for CT and presentation within 24 hours. And the only exclusion was if patients were had pre-existing cognitive deficits, which made outcome assessment difficult. So what did we do? This is what we call our core biomarkers paper, and this was published a couple of years ago now. And the data that you have are for 2,867 patients where we collected, where we collected data on these 6 biomarkers. So what are the things that we use the biomarkers for? Well, the first one was for triaging patients for CT, and this is at admission, probably not relevant to most of the patients we take care of in our ICU, but has some insights that it can deliver. And what we've used it for mostly is in mild TBI. And in mild TBI, usually patients are selected for CT using CT decision rules. This can be the New Orleans criteria, Canadian CT head rule, CHIP. In UK, the NICE guideline for head injuries, and the Scandinavian guidelines. And these have varying sensitivities and specificities. For example, the New Orleans criteria are very, very sensitive, but not very specific, whereas the NICE guidelines from the UK are much more specific, but less sensitive. What we found was that when added to any of the above CT prediction rules, GFAP improved prediction of abnormal CT beyond clinical variables. And at about 12 hours, GFAP on its own outperformed all these decision rules. S100 and UCHL1 have previously been shown to be helpful in prior studies, but we couldn't find any additional benefit from these two in our study. However, it's really important to make the point that both UCHL1 and S100B have very sharp kinetics and probably have come and gone by the time we were looking at these patients at 12 hours. It's probable that GFAP will still be superior, but we haven't conclusively shown that in an early time point. So how does it work? So this is, we've taken for each of these CT prediction rules, we've used the optimal sensitivity for that tool and looked at the specificity, and you can see that the specificity varies substantially. But when you add GFAP, the transition of specificity is from 14 to 33%, 34 to 69, and so on, and the increment in specificity is this. So that's statistically interesting, but what does it mean in real terms? Well, this is the number of CT scans avoided on a baseline of just under 2,000 patients. So it's a substantial number of CT scans that might have been avoided by adding biomarkers. So that's important in the mild TBI population, but for us, the flip side is important. Patient comes in early, has an early CT scan as part of a trauma series, and the CT head is normal. What happens if you subsequently discover that the GFAP level is elevated, particularly if it's very highly elevated, beyond about 150, getting up to towards 1,000? Then it's a very strong predictor in those centers. We're not using this clinically as yet, but places like UCSF, which are using this clinically, it's a very strong indicator to relook and repeat a CT, particularly if there's a secondary rise in GFAP, and we'll come to that in a minute. The next thing that happens for these patients, if they come in with a normal CT, but have a GCS that's discordant. So someone comes in with a GCS of 3 and has a CT that looks terrible, it's not surprising, and an MRI is not interesting. It may be necessary for prognosis later on, but not at the early time point. However, if the CT doesn't show very much, but the GCS is very low, the difficulty is understanding whether this patient has very severe diffuse axonal injury, which has not been picked up by the CT, or alternatively is just perhaps sedated because of management outside in the pre-hospital phase, or is drunk, or is on recreational drugs. And the question is whether biomarkers might help us with that. Well, why is that important? It's important because further down the line, a proportion of these patients wind up having very severe intracranial hypertension, which is not responsive to stage 1 or stage 2 therapies and requires either deep hypothermia, decompressive craniectomy, or barbiturate coma. If the underlying brain injury is relatively mild, and this is a secondary insult, then the intracranial hypertension is a cause of poor outcome. It's not necessarily going to have a bad outcome if you treat the patient's intracranial hypertension. But imagine the patient here who has a brainstem lesion. What you have here is a contemporaneous CT and an MR with a bilateral brainstem lesion and a hemorrhage on one side, or diffuse axonal injury that's widely distributed, shown here on a susceptibility-weighted image. In that setting, one of the questions you have to ask yourself and discuss with the family is whether you should proceed to a decompressive craniectomy or barbiturate coma when the overall outlook is likely to be bad, because controlling intracranial pressure there is not the driving cause of outcome. It's going to be primarily the underlying injury. So the MRI scan can show these prognosis-defining pathologies, but it's not feasible to take every patient for an MR scan as they come through the door. And by the time their ICP is uncontrollable, you can't actually take them safely, or the risks are higher. And the question we wanted to ask was whether biomarkers could provide enriched populations. And in this paper that was published earlier this year, we found that in patients with moderate to severe TBI, brainstem injury was associated with higher concentrations of NSC, tau, UCHL1, and GFAP. And if you wanted to reduce the risks of transfer, it also reduces cost, but the cost reductions are minimal, but it's the risks of transfer, then GFAP would allow you a 94% sensitivity. Now, this is not perfect, and you may choose to do MRs more than that, but it certainly helps your decision-making and is one more piece of the puzzle. So we've talked about how it might influence imaging, both for CT and MR. What about the relationship to type and burden of injury? As I showed you in the biology, individual biomarkers are expected to relate to individual subcellular locations, and you would expect, for example, NFL and tau to be elevated in diffuse axonal injury, and UCHL1 and GFAP to be elevated in contusions where there was damage to cells, both astrocytes and neurons. So in a paper we published recently from the Center TBI, what we looked at was the different kinds of CT findings, from no acute abnormality going through skull fracture, each of these, and finally diffuse axonal injury, and looked at how each of the biomarkers performed. First thing is, all of the biomarkers performed relatively well. They're elevated in all patients with different kinds of injuries to different extents. Interestingly, it's consistently elevated. Tau, GFAP, and UCHL1 are elevated even in patients who show no CT abnormality and just show a skull fracture, suggesting that these patients have some degree of occult brain injury that is not detected by the CT. That's not surprising. We've known it for some time, or suspected it for some time, but this provides proof of that. But the issue is this, that when you looked at the diffuse axonal injury patients, they were really no different from the other patients at all in terms of biomarkers, and specifically tau, top left, and NFL, bottom right, were not significantly different, and these are axonal and dendritic injury markers. So it looks as though the elevation of specific biomarkers at admission, this is within the first 24 hours, is unrelated to injury type. And the level of elevation is more related to injury burden. And this work from Dan Whitehouse looked at the overall volume of injury. And it may be, one hypothesis is that TBI impacts different cell types and compartments roughly equally, but we know that that's not the case. I think it's much more important to understand that the biomarkers, kinetics affect this. And because NFL, for example, is a late rising biomarker, it only gets to its peak by 1 to 2 weeks, maybe making those decisions about what type of injury there is a little more difficult. So we've talked so far about diagnosis and injury burden. What about disease progression and response to treatment? I think the people who've done this best are the people in the Karolinska in Stockholm, and David Nelson, Bo Michael Belander, and now Eric Thielen have been pioneering using S100 primarily, both in subarachnoid hemorrhage and traumatic brain injury. And it's useful to think about this in a model because it's something you have to do for yourself and understand how it works. What they find with S100 is that there's initially an extracranial contribution which rapidly dies down, and then there's an initial cerebral contribution. And where the patient is recovering rapidly and the injury the injury resolves rapidly, this blue line is followed and it comes back within 48 hours to baseline levels. However, if there's ongoing brain injury, you get further peaks or a prolonged period of elevation. And if you have a secondary insult, you can have a secondary peak. Now, the use of this is very rational, but hasn't really been widely, if you like, documented. And those of you who are interested in trying this, I would advise you to go to this review article. It can also be used not just for ongoing therapies, but also to devise new therapies. And this paper from Elizabeth Wild and colleagues in the Journal of Neurotrauma last year really talks about the 3 ways in which we can look at this. There's the severity, which we've already talked about. The bigger the injury, the greater the burden of injury, the higher the peak. Progression, which is the duration of the elevation of biomarker, rather like the Karolinska group are doing. But also we can use it as a surrogate marker in trials, because if you intervene and you find that the biomarker levels drop more quickly than in the placebo population, it's a really good pharmacodynamic variable of efficacy of an intervention. And this is being explored by many companies and protocols over the next 2 to 3 years. What about prognostication? We've talked about other things. Well, yes, it looks as though it is prognostic. So this was the paper that came out in Lancet Neurology. We know that we have established prognostic models from crash and impact, and these explain about 25 to 35% of the outcome variance. What we found is that this prediction was significantly improved by adding biomarker data, best for UCHL1, and improved mortality prediction by 12.5% and unfavorable outcome by about the same amount. So I think future outcome models will take account of this, and this is a graphic representation. In the last 30 seconds or so, I'll just talk about whether biomarkers can predict late volume loss in the brain and also neurodegeneration. And there are two pieces of evidence to support this. The first comes from this paper from David Sharp's group based on the CREACTIVE study and the BioAct study from Imperial College in London, published in Science Translation Medicine year before last. And what they did was to measure biomarker levels across the first 6 weeks and use the NFL peak at 10 to 42 days, individualized for each patient, and showed that it was still abnormal at 1 year. And they found that NFL at peak levels correlated with diffusion tensor imaging. And here you have the area under the curve being depicted for each of the biomarker levels. But basically, GFAP and UCHL1 tended to predict gray matter loss, and NFL predicted white matter loss between 6 and 12 months after TBI. In a more recent study from Cambridge, we followed up our Cambridge cohort, and these are patients who had moderate to severe TBI and had NFL and GFAP at 6 months measured, and MRI at 6 months, and at about 5 years. It was actually 5 to 9 years after the injury. And what you can see is the regional brain volume loss between 6 months and 5 years, shown for both gray matter and white matter. You can see for the gray matter, there are some of the usual suspects. The medial temporal lobe, which has been implicated in long-term neurodegeneration, is also picked up. And then there are key white matter areas that have also been shown in the past. What we did also was to show that these patients had brains that were older than their chronological age, and that chronological age was described as the predicted age difference. So the gray graph here is for controls across the age range here, and the green graph is for the patients. And you can see that right across the range, regardless of when they had their brain injury, there was an increase in predicted age. They were on average, in both white matter and gray matter, between 5 and 10 years older than they should have been 5 years after the injury. So what does this have to do with circulating biomarkers? Well, what we found in the patients we could do sequentially was that the NFL levels at 6 months predicted subsequent volume loss over the next 5 to 10 years. And this is a finding that we're seeking to replicate in the Center TBI study. So take-home messages: protein biomarkers are at or near the point of wide implementation. GFAP plus minus UCHL1 in the Abbott point-of-care device and NFL are receiving the most attention. Kinetics make comparisons quite difficult, and S100 may still have a role. It's part of the CT triage in the Scandinavian guideline system. But for S100, you need to think about extracranial contributions. Literature in the mild TBI population is important for the mild TBI, but it may be relevant for intensivists who are taking care of multiple trauma with TBI present or absent, and help us make that difference more carefully. Biomarkers may identify CT normal subjects at risk of DAI and suggest they should have an MRI. And biomarkers may improve prognostication both in the acute and the late phase. Thank you.
So great job, really fascinating talk. We're going to take 1 or 2 questions. So anybody with a question?
David, I have a question. We heard before a relatively simple tool like pupillometry. When do you think these specific biomarkers will become available to daily or routine outside the studies?
So the US are already using the Abbott point-of-care device in the emergency department, and I think they've also got EMA approval, so it's available for use. The question about cost effectiveness is something that needs to be addressed a little bit more. And I think for the patient who arrives in the ED and you're not certain whether to do a CT or not, it's a reasonable thing to do, not so much for cost saving, but to prevent radiation burden. For us to use it in the intensive care setting, I think we need to have a little more experience with it, because sequential use has not been addressed very carefully. It has been for S100B, but mostly in one center, I think. There may be other centers doing it. But I think in the next 3 to 5 years, the exact role that they're going to have will be much more crystallized, and we'll be able to have a better answer for that.
Maybe a follow-up question about translation, since I don't see any questions from the audience. Follow-up question sort of about the translation into a practice. Do you envision long-term wise sort of finding like sort of the idea the best biomarker, or do you envision a future where we have a panel of biomarkers and that then addresses a number of questions, as you illustrated? It could address prognostication or detecting secondary worsening. What do you see in the future?
Yeah, so I think that's a combination of three things. It's the sensitivity of the assay. So for example, the UCHL1 assay is not, let me put this diplomatically, it's not as good as the GFAP assay even on the Quantrix panel. The second is the kinetics. NFL is a much later biomarker, it peaks at 2 weeks, and it probably integrates the burden of injury over those 2 weeks. So it has benefits and drawbacks. Benefits in that it's integrating it with a single measurement, drawbacks in that it's not telling you dynamically about what's happening. And the third thing is what you want to know. So for example, maybe GFAP at the first time point, but NFL and GFAP at late time points may say, these are the patients who are at risk of late neurodegeneration at 6 months. Make sure you follow them up and look for inclusion in trials looking at molecular imaging biomarkers.
Okay, thank you. Thank you very much. So we move on to the next speaker, Professor Pierre Bouzat from Grenoble, France, and he will discuss about invasive monitoring with brain tissue PO2.
Thank you, Mauro. Thank you for the introduction. So we're going to talk about brain tissue oxygenation, and I have no conflict of interest for this presentation, but I've been using a PBO2 sensor for more than 20 years. So cerebral hypoxia is common after diverse cerebral injuries, and we can divide the physical determinants of cerebral hypoxia in two categories. One could be the macrovascular dysfunction. It means that if the CBF decreases, the arterial oxygen content decreases, then you have a cerebral hypoxia. The other thing is the microvascular dysfunction, which has been described more recently and could be summarized with an impairment of oxygen diffusion from the capillary to the surrounding tissue. So the microvascular dysfunction has been discovered 20 years ago by the group from Cambridge. And what they've shown is that they compare zones with normoxic regions, and they compare to regions that are hypoxic. And they look at the microvascular function. As you can see, the microvascular function was not different between the low PBD2 zone versus a normal PBD2 zone. And they perform an hyperventilation test. And you can see that there was a decrease in CBF in both regions. But in the hypoxic regions, the oxygen extraction factor could not increase. And they performed microscopic electronic in the hypoxic zone, and what they found is that the brain capillary was surrounded by brain edema and causes an impairment of oxygen diffusion from the capillaries to the surrounding tissue. What is really important to understand with the microvascular dysfunction that it could happen despite a normal CBF. In a rat model of TBI, we also shown that this is a control group, and you can see rats here with after traumatic brain injury, what impacts acceleration model. And you can see the swollen of the astrocyte and foot that compressed collapse of the brain capillaries, and the compression of the brain capillaries can explain by itself a decrease of brain oxygenation despite a normal CBF. Also, variation in the calibers of brain capillaries could act as a disturbance for the transit time of red blood cells into the brain capillaries, and the heterogeneity of mean transit time of red blood cells inside brain capillaries can also explain brain hypoxia. So what we are doing is putting a probe invasively to measure a very local tissue. And this is one of the main limitations of the monitoring. If you look at the surface, it's only 7 to 15 millimeters square. And I think this is one of the main limitations of this monitoring. But the success of this monitoring is almost the failure of other monitoring. And the NIRS technique has many drawbacks. You can have an extracranial contamination. The satellite bulb jugular oxygenation is too global, and it can induce complications that can be fatal for the patient, deadly like a thrombosis of the jugular vein. So the reason why brain tissue oxygenation has become one of the most important tools to measure brain oxygenation is the failure of other monitoring. What are the normal values? The normal values come from the operating room. This was established by people doing neurosurgery. You can see that you can wait until you have stable values. It's around 2 hours to have stable value. It takes you 2 hours. The normal value is around 20 to 30 millimeter of mercury. One of the criticisms of brain tissue oxygenation, if you increase PaO2, then you increase PbTO2. Indeed, the value of PbTO2 depends on oxygen transport, which is the produce of the arterial oxygen content times the CBF. And arterial oxygen content depends on hemoglobin concentration and PaO2. That's why when you increase PaO2, you increase the PbTO2. But if PbTO2 was only dependent on the arterial oxygen content, and you have the black line, if PbTO2 was only dependent of PaO2, it was a dashed line. But if you do an hyperoxy test to the patient, the value of PbTO2 is in the gray zone. It means that it's not dependent on arterial oxygen content, not only dependent on oxygen transport, but also on diffusion and CBF. But obviously, you have a clear relationship between PaO2 and PbTO2. Meyfroidt, what it was in the US, has clearly showed that according to different PaO2 range, you can see the decrease of PbTO2. The same relationship applies for hemoglobin concentration. You can see the drop of PbTO2 when the hemoglobin concentration goes down and goes under 9 grams per deciliter. That's why some people can titrate the transfusion of red blood cells using PbTO2. And beyond arterial oxygen content, beyond CBF, diffusion obviously is a key factor, and PbTO2 can be seen as a marker of brain edema. Probably the best relationship was found by Rosenthal and al. 20 years ago. And you can see that PbTO2 during different challenges was proportional to the produce of CBF time the venous arterial oxygen tension difference. It means when you have a low PbTO2, you may have a technical problem, the probe doesn't work. You can have a low CBF. You can have a low arterial oxygen content, low PaO2, low hemoglobin concentration. But you can also have a low diffusion. Regarding practical consideration, where to insert the monitor. Ideally, you should insert in the tissue at risk, but nobody knows where the tissue at risk is. So what we are doing is putting the sensor in the normal parenchyma, in the right frontal lobe. And doing this, what we can say is that the variation in regional CBF are well correlated to the variation in global CBF. So you have a clear relationship between what you are manipulated at the regional level and what you are manipulated at the global level. How to assess its functionality? You can perform an hyperoxy test, and the PbTO2 should increase between 100 and 300%. What about the prognostic value of PbTO2? Episodes of brain hypoxia have been shown to be an independent prognostic factor. And it's not only the episode by itself, but it's also the duration of the episode. And it comes to the concept of PbTO2 burden. This is new data. We combine data from Grenoble and from Innsbruck with my colleagues Raimund Helbok. And you can see you have on the x-axis, you have the PbTO2 value and the duration on the y-axis. And the blue is patients with good outcome, and red are patients with bad outcome. And you can shape a line that differentiates patients with good from bad outcome. And so, if you look at the different threshold, you can see that having a PbTO2 of 17 for 5 minutes, and you have a odds ratio to have a bad outcome. If you have 20 millimeters of mercury for 90 minutes as well, but you can go higher, and 25 millimeters of mercury for 360 minutes, also associated with a poor neurological outcome. So the concept of PbO2 burden is also very important to understand. At the bedside, what is the additional value of PbO2 for the diagnostic of at the bedside, for the diagnostic, everyday diagnostic in the ICU? PbO2 had information about CBF. Here is a study we made in Lausanne in patients with TBI. You can see that there is a prediction curve for low CBF. If you have only an ICP probe, you can see that the prediction is pretty bad. And if you had the PbO2, then you can see that the accuracy improved, and you are more able to diagnose low CBF at the bedside. More important is probably the relationship between PbO2 and PaO2. Here is unpublished data. This is patients with PbO2 variation according to PaO2 changes. Each line is a patient. We have 15 different patients. And the slope of the line is different according to regional CBF. So the oxygen reactivity depends also on the regional CBF. And this was also shown by this group. And you can see low PbO2 is associated with low regional CBF, and the oxygen reactivity was impaired in patients with low CBF. It comes to the concept of oxygen reactivity index. It is a relationship between CPP and PbO2. This was the first description of the ORX. In this patient, you can see that there is a clear correlation between CPP variation and PbO2 variation. And in this patient, the PbO2 remained stable even between variation of CPP. This was also demonstrated recently, and you can see the relationship between CPP and PbO2. And this group described two types of patients. Some patients with almost linear relationships between CPP and PbO2, and some patients with no influence of CPP variation on PbO2. So maybe we can use PbO2 for the adaptation of CPP. So this is a practical algorithm we published 10 years ago with Mauro. When you have a brain hypoxia, the first thing is to look at the ICP value. If the ICP value is high, you should treat it. Then you can adapt sedation, test CPP reactivity, check PaO2 ratio, and ultimately give transfusion, adbucitone transfusion in the patient. What about the impact of PPO to guide this strategy on the outcome? For now, we only have one study, which is a BOOST2 trial. They show that you can decrease the PPO2 burden when you measure brain oxygenation, as was a signal as well towards a better outcome in patients treated with PPO2. But if you look into details, you can see that patients in the ICP-only group had a higher proportion of basal system compressed, which might explain completely the result of the study. There is ongoing study. One of the study is led by our group. His name is OxyTC. The OxyTC trial is now ended. So we have two groups, ICP plus PbO2, and the management is different according to the group where you are. If you have the PbO2, then you have specific intervention to improve brain oxygenation. And here are preliminary data that I show you. I will ask you to do not take photo, please, because this is not. This is only preliminary data. This is only the demographic characteristic of the patient. So we include 159 patients in ICP group and 168 in the PbO2 group. You can see as young male patients. The GCS were relatively low. Almost all patients were intubated under norepinephrine. And you can see that the ICP at randomization were not so high, and the PbO2 was pretty low on randomization. We are now doing the final analysis, and we hope that we can have the results within the next month. So here my take-home message. Episodes of brain hypoxia are deleterious. It may be independent of ICP. We call that the silent hypoxia. To depict brain hypoxia, you have to monitor brain PbO2. You have to put a sensor inside the patient if you want to depict them. The interpretation is quite complex. It depends on CBF, hemoglobin, PaO2, and diffusion. And there was a signal on beneficial effect on PbO2 guided strategy that should be confirmed by ongoing RCT. Thank you for your attention.
Thank you, Pierre, for this excellent review and talk. So we are open for questions, and actually, since we are running faster than a Swiss clock, we have still 10 minutes if we want to have questions also for the previous speakers. Jan?
All right, everybody come to the microphones. I'm going to just start out. Pierre, really amazing talk, such fascinating data, especially the last part with this trial. I mean, I can't wait to see the results. Like last week, I was on service and I had a patient that had a subarachnoid hemorrhage and had like ICP elevation, but always the ICP in deep sedation was like, in 30. So it wasn't like, 35, 40. And, but the brain oxygen was always normal. And whenever we, decreased the sedation, patient was following commands. And so in my sort of anecdotally, I always feel like in this middle zone between 20 and 30, that's where I see there's a huge benefit from brain oxygen monitoring. Are you going to be able to look at that also in this fascinating clinical trial data?
Yes, I think we will look specifically in patients with intracranial hypertension. And this is a subgroup of patients we're going to look at, because I totally agree with you. The thing is, in the gray zone, PbO2 helps you not to do anything. So, because sometimes you don't have to do something, and doing something is harmful. So maybe PbO2 helps you to not do something. But the thing is, initially when we set up the study, my opinion is that we should have two different ICP levels, according to you have a PbO2 value or you don't have the PbO2 value. But it was not ethical to have different ICP value threshold between the two groups. So we decided to keep the 20 threshold. But I think ideally the ICP threshold maybe could be higher if you have the PbO2. But we will not be able to demonstrate this with this study.
Pierre, I have a question, because we have discussed pretty much about, in these studies, about traumatic brain injury, and you have shown the relationships between brain oxygen and blood flow. So do you use, and what is your experience in patients with vascular conditions like subarachnoid hemorrhage?
The use of PbO2 in SAH patients,
yes.
Yeah. It's more tricky, I think. You can see the PbO2 monitoring as two options. One could be that you insert the monitor just to depict the vasospasm, but you have to be sure that you are in the good zone, in the zone of the DCI. If you are not in the zone of vasospasm, though, it is not helpful. One way is to use the PbO2 as an additional tool on top of ICP monitoring to better treat our patient. And I think this is more, the way we use it right now is more to treat patients with ongoing rise of ICP, and we use the monitor to adapt our therapy more than to detect a vasospasm.
Mm-hmm.
Thank you.
Yeah, question from the floor, please. Identify yourself and wait for the mic.
I'm from Greece, and I'd like to ask you a question about. First of all, thank you for your excellent presentation.
Thank you.
And the question is about the voxel graph. I'd like to ask two questions. First of all, you said that a pressure of 25 millimeters of mercury would be for 300 minutes, if I remember correctly.
360.
Yes. Would still be detrimental.
We don't know. We don't know. This is only an association. There is no causal relationship. We just look at the association. So it's very hard from a simple association to say that it is a target that we should use to treat patients. Okay? So what we have shown is only association between different threshold and duration, but I cannot say that this is the threshold you should apply, you should treat the patient when it goes for 400 minutes and the PbO2 is less than 25, you have to treat the patient. No, this is not true. This is only the correlation. This is not appropriate for treating patients.
Okay, because most of us would probably feel a bit safe if they had
for sure,
25.
For sure.
If they had 25 for lots of time.
But you have to be cautious when you look at association. It's different from causal relationship. And I'm not sure whether this is new targets. I don't think so.
And the second part of the same question is, in that voxel graph, you could probably see some blue areas even below approximating 12, 10 or 12, something like that, if I remember correctly. How would you comment on that? How would you justify that? Physiologically?
Yeah, physiologically, yes. The thing is, the poor outcome may occur despite having good oxygenation, or on the opposite, even with low PbO2, sometimes you can have good neurological recovery, because it depends on the duration. But it's hard to explain, but I think because it's not only dependent on the brain oxygenation. There are multiple factors that will influence the neurological outcome. So it will be too simple to have a clear line clearly separating two different categories. Obviously, we have some overlap, like in the real life.
Yeah, one more question. When you introduced, in the beginning, you talked about other monitoring techniques, right? And you framed the brain oxygen monitoring in the context of jugular bulk oxygen measurements not being used. But do you see a role, because they're very different, obviously, right? And the fact that the jugular bulk oxygen, for example, gives you an idea about more global oxygenation. Do you see a role of the combination of the two, sort of to, in some ways, benefit on each one, or do you think that that's great?
The main issue with jugular bulb oxygenation is the complication of which is the thrombosis of the jugular vein. We have seen many patients with such an event because many of the patients are contraindicated for anticoagulant, and we put a catheter into a jugular vein, and then you may have a thrombosis, and it's completely dramatic for the patient. I think the harm outweighs the benefit. This is my opinion.
Great. Thank you very much.
So we're going to continue, and the next speaker is Raimund Helbok from, I think, Innsbruck, right? Still, Raimund. And Raimund is going to be talking about metabolic monitoring of the brain. Raimund.
Thank you very much for that nice introduction. It's good to be here, and it's fantastic to see so many people in the audience. I think things have changed over the last years that more and more people are interested in multimodal neuromonitoring, and I'm concentrating on metabolic monitoring. So you heard several talks about how we try to identify, to detect patients who are at risk for secondary brain injury. And there are several methods, non-invasive, invasive methods. And our ultimate goal is to prevent secondary brain injury. And you've heard something about ischemia, hypoxemia, ICP today in the morning session. And I'm gonna focus on brain metabolism. If we talk about brain metabolism, we focus on glucose metabolism. We have to know that the brain is actually consuming 50% of the body's glucose. So that's a very important nutrient for the brain, as oxygen is as well. And usually glucose is metabolized to pyruvate and the citrate cycle for energy production. And energy production is quite efficient if mitochondria work and if enough oxygen is there. And if that is not the case, you see a low energy production, a lactate increase, and that's what these metabolic signature can actually give us a lot of information about whether hypoxia or ischemia occurs. And I will talk about many other implications which we can identify using metabolic monitoring. So from a more broader view, there are several tools how we can monitor metabolism. We have neuroimaging. Neuroimaging has advantages and disadvantages. Advantages that we can actually cover the whole brain, for example, with PET analysis or spectroscopy. But we only have one time point where we actually make the investigation. Other methods like the jug bulb catheter, we can measure oxygenation. We can also measure through microdialysis metabolites, which are flowing out of the brain. It's more a global information, or we can use cerebral microdialysis, and which is obviously a focal measurement and invasive tool still available. And I will focus on cerebral microdialysis monitoring in patients with acute brain injury. And as said, it's still an invasive measurement. You have this pump system with a very low flow rate, and you recover fluid directly from the brain, extracellular fluid. And you need obviously to know where these probes are, also for correct data interpretation. And as the membrane has a minimum of 20 kilodalton, we can actually measure the equilibrium of all these small molecules, as you can see here, which is beyond ischemic monitoring. And that's quite important, because you always have to ask the question, do we only need an oxygen monitor, or do we need any additional monitoring tools? And as you see, we also have glucose monitoring, glutamate monitoring, and glycerol monitoring if we apply that. And you've seen this figure before. So we have to prove that there is an additional information, additional value in detection of our outcome parameter. It could be long-term outcome, it could be cerebral perfusion, as shown in this study. And you see, when adding cerebral microdialysis, we have even a higher area under the curve beyond PbTO2 measurement. So I'm gonna talk about research-wise and clinical-wise about the use of cerebral microdialysis to monitor ischemia as basis, and then we also have the additional information on mitochondrial function, glucose, biomarkers, but you've heard a very nice talk already, and I end up with some thoughts on precision medicine. If you're interested in cerebral microdialysis, I think that's a very important booklet from Urban Ungerstedt, who is the founder of cerebral microdialysis, and you can, I think, request it by the company. So the concept of ischemia, and you have nicely heard how we think about ischemia in the brain, and this is the view from the metabolic derangement. And there's some studies, very old studies, which show that there's a certain threshold where the deprivation of oxygen leads to a lactate increase, lactate-pyruvate ratio increase, and the glucose decrease. So that's a very simplistic model, and this is a patient just as proof of concept where you can see oxygen monitoring here, and you can see the decrease in brain tissue oxygen tension measured by invasive method, and on the 4, 5, 6, and the metabolic information with an increase in lactate-pyruvate ratio and the decrease in glucose concentration, which is evident for vasospasm. And that's what we've seen in the angiograms, so severe vasospasm here the monitoring tools. And after the application of the therapy in imodipine, you see the decrease in lactate-pyruvate ratio, the increase in oxygen tension, and the result here. So this is a proof of concept that the method actually works. It's very difficult to put that into clinical trials because every patient is different, and obviously this is a selection of a very good patient to demonstrate the feasibility. During my time at Columbia, we made one retrospective analysis and looked at evident CT ischemia in SIH patients, and we found that after the detection of ischemia is here, so it's several hours that the metabolic information is actually deranged before. So that's also an important information. So we need this biological or this chemical information to predict and obviously to intervene. So this is the concept of ischemia, which is also nicely summarized in the international consensus statement. But there is a huge additional information underneath the sea level. Underneath ischemia, it's mitochondrial dysfunction. And as I said at the beginning, mitochondria, they are important for energy production. And if we don't have the possibility to metabolize pyruvate is increasing. And in addition, also lactate-pyruvate ratio. And this is the difference between mitochondrial dysfunction, the signature here, and the ischemic signature where pyruvate is decreasing. And that mitochondrial dysfunction occurs in the brain of TBI patients, SH patients, ICH patients is from the concept very obvious. And I think there are several physiologic factors. If they are pathologic, they also influence mitochondrial function. This is not a TBI, because we know it very well from TBI patient population with intracerebral hemorrhage. You see two catheters here. And after the operation, you see that CBF was not a problem anymore in these both areas where the microlysis probe was. But you see a signature of mitochondrial dysfunction with elevated pyruvate in the area around very close to the previous intracerebral hemorrhage, which was not evident in the normal appearing brain tissue. And this means mitochondrial dysfunction. So it looks like a normal brain on the CT scan, and maybe also the brain tissue oxygen tension is normal, but there is an additional information, metabolic information. And that can actually happen in a patient from one day to the other, that you're going to have a signature of mitochondrial dysfunction before, and then a ischemic signature occurs where pyruvate is decreasing and lactate-pyruvate ratio is increasing. So what to do in clinical practice? And that's very difficult, and there are only a few studies which are mostly observational, single center, and one study I'm gonna provide you the results here. The idea is to prove the concept whether metabolic monitoring and the information we get, especially from the lactate-pyruvate ratio, can be translated in an algorithm for treatment in patients with subarachnoid hemorrhage. So this is the treatment protocol. Obviously, as I showed you the patient before, if lactate-pyruvate ratio is increasing, then the doctors got the alert and they had to intervene in a stepwise approach. So the finding was that cerebral microdialysis, there were the definition of a major event and the minor events by the lactate-pyruvate ratio above 40 and above 30 over the time for 2 hours. And they found that in these patients, these events were quite common. So that's first a very important information. And if they intervene, they were also quite effective in 2 out of 3 patients. And it was possible to normalize the energy metabolic state. So this is also more a proof of concept study. And the incidence of DCI was very low, especially if you compare the poor grade SIH patients which were eligible for invasive multimodal neuromonitoring. So 10% DCI rate is a very low rate, but obviously there was no control group. And the very interesting part is also that adherence to the protocol makes sense and also was translated to a better metabolic response. So in this study, they used the information of cerebral microdialysis on the patient bedside. And this is now another study, which is a sub-study of the different blood pressure targets in cardiac arrest. You know, the result was published in New England Journal of Medicine, over 700 patients. And the target was a different mean arterial pressure from the beginning in these randomized patient population, around 77 and around a bit more than 65, 2 distinct patient population after cardiac arrest. This study was a negative study, but in a subgroup of patients, they had cerebral microdialysis monitoring as well, in the jug bulb microdialysis monitoring. And the results showed that these patients where the target was a lower mean arterial pressure, lactate-pyruvate ratio was actually higher, but it was not clinically significant. Some other metabolic information was significant. And in terms of outcome, the CPC outcome, there was a significant result that the metabolic information was actually translated to a worse outcome in that group of the lower mean arterial pressure. So in this study, microdialysis was not put as a point where a decision was made afterwards. It was a lump sum of patients which were randomized to higher blood pressure, lower blood pressure, and then the microdialysis information was afterwards. So the question is whether we actually, if we put this metabolic information at the beginning and then intervene with different targets in blood pressure, whether that could actually have an effect or not. And the interesting information, I think, is the ones with poor outcome, they have a deranged metabolic information, so somehow a prognostic value in cardiac arrest patients. So I was talking about ischemia and mitochondrial dysfunction. The next point is glucose management. And we've heard an excellent talk today in the morning in the opening session about glucose management. And there's still a huge debate about what the optimal glucose management for patients in the ICU are. And we have to say that neurological patients are mostly underrepresented in these large trials. And the question is whether neurological patients are different. What we fear is hypoglycemia, because we know that the brain needs glucose, so there's a certain level of lower oxygen, and there's a certain level also from animal studies which show that beyond 200 milligrams of deciliter is deleterious for the brain. That's the same in ischemic stroke, in TBI, in other diseases, and that's why the consensus recommendation, well, it should be somewhere in between. We know that the brain needs oxygen. I talked about that before, and it's very sensitive against changes, glucose, against changes of glucose in the blood. And there also from animal data, there are signals that more glucose is needed or more nutrients are needed in the brain, especially in the situation of the damaged brain. In one study published by Mauro several years ago, he could show that the tight glycemic control measurement is associated with lower levels in the cerebral microdialysate, and which are critically low levels, and these patients also had worse outcome. And by higher glucose measurements in the serum, we also achieve higher glucose measurements in the brain. So the question is what the optimal target is, and this is a very recent review just published a few weeks ago about studies on traumatic brain injury. And the authors concluded that blood glucose increment is a potential, especially if we see that cerebral glucose is decreasing. So there is no clear recommendation what to do now, and there are several people and also data who support the idea that glucose levels should be strict below or between 80 and 110 milligrams per deciliter, and in some centers it actually works that you prevent hypoglycemic episodes, but maybe in other centers it would not work. This is our glucose protocol, how we treat these patients with severe brain injury. So we target values between 130 and 180. Obviously, what to do is decrease insulin levels and optimize nutrition. And by monitoring the brain in glucose, we often realize that we do not perform properly in our nutrients to the patients. So that's the same in oxygen monitoring. Sometimes oxygen is decreasing, and you see that CO2 level is right out of range where you actually don't want to have CO2 levels. So it's a marker, it's a biologic, physiologic marker, which indicates that something is going wrong. So, but there are also limitations of the methods. It's a focal measurement, and you have to be aware of the limitations. And I have to say gratitudes to Urban Ungerstedt, who borrowed that slide to me, where he could show that in a patient with 3 microdialysis catheters, you get different information wherever you put the probe in. That's logical, and obviously that questions whether these focal monitoring tool can actually provide us or guide clinical treatment. But obviously obviously you have to ask yourself, what is the area you wanna prevent secondary brain injury, and that's mostly the area where we also put the probes in, and it's quite difficult to answer the question right now with our intervention. What happens in that area of the healthy brain? We think that regulation of flow is still sufficient in these areas, meaning autoregulation is still preserved on the cellular level. What about prognostication? I think that's an interesting part, that which values can we actually take for prognostication, and what we found in one study is that glucose is quite stable, although it's lower in the perilesional site, but the prognostic information is the same, which is not true for lactate-pyruvate ratio and all the other measurements. So maybe the information on glucose is of value. And this is the recommendations also of the consensus statement published several years ago now, that although it's a weak recommendation, but there's some evidence that glucose can be integrated in such a management concept. In the last minute, I briefly talked about biomarkers, but it was very nicely covered. The only point I want to make is that the brain is different to what we measure in serum or in the blood, and there is the possibility to measure tau protein also in the brain, in the microdialysis. We can measure markers of neuroinflammation. We can measure proteomics, and this field is actually wide open. And if we compare serum levels to levels directly derived from the brain tissue, we can see that we get a different information, which supports the idea that the brain is a separate compartment. And whatever we derive from the blood can be helpful in prognostication, but maybe not for the treatment decision. And the last point I want to make is what actually the whole theme of this conference here is, and also the round table. Are we going towards precision medicine and neurocritical care? And I think yes, multimodal neuromonitoring or monitoring is the way to identify different optimal levels for different patients. And you're going to hear about other multimodal neuromonitoring tools in the next talks, also in the previous talks. So maybe that's the future, that we actually identify patients which benefit from specific interventions. Thank you very much for your attention.
We're a little bit over time, but I think we have time for one question. Raimund, so in practice, right, when you're rounding, so that's a lot of information to all put together. How do you do that? I mean, I think we have a talk that is entitled, How Do I Put It All Together? But maybe also from you to hear how you in practice sort of integrate all of this information on a patient.
So working in an academic hospital, we have the beauty that someone, in addition from research point of view, actually summarizes data for us in clinical practice and gets the information about the optimal brain tissue, the optimal mean arterial pressure, and so on. In terms of microdialysis, I think it's more straightforward, because you see the trend over time, and knowing about the disease, about the severity of the disease, about the probe location, that can be more easily integrated in clinical practice, because you also see these changes which are over time, and you have certain time to react, and that's also very important information, that we do not react on single measurements. We look for trend analysis to understand the pathologic changes where we should intervene.
Thank you. Thank you very much, Raimund. There is a question, maybe? Just
There is
a short question.
Yes, it's just a small one. How do you... Okay, nice. Thank you again for your talk. How do you choose glycerol over glutamate? Which one did you pick on your microdialysis monitor, and why?
So again, the benefit of working in an academic hospital is that we can actually analyze both, the information is totally different. Glutamate is more for excitotoxicity, and glycerol more for cell degradation. So for marking for ischemic injury, for example, vasospasm, DCI, and I think that there's a lot of information in glutamate. If you ask me which one I would choose, because you see more the pro-inflammatory, the excitatory information of the brain. That could be fever, that could be many things that can actually be integrated in that treatment concept.
Excellent, thank you very much. So we move to the next speaker, André Denault, who will discuss about non-invasive monitoring. So the mixing of EEG, Doppler, and near-infrared spectroscopy. Thank you very much.
Thank you very much. Thanks for the invitation. Just can advance. So I work at the Montreal Heart Institute. My disclosures are shown here. And I'm also supported by the Montreal Heart Institute Foundation. So my objective on this presentation is to understand the tools we use in cardiac surgery, and also the approach that we've been developing, particularly out on the interpretation of brain oximetry. So if ever you're interested, this is something we just published recently about this topic. So we've been using brain oximetry in 2002. Since 2002 at the Heart Institute, in 2015, we had a transcranial Doppler. And in 2017, we started using process EEG. In 2020, now we have the ability to combine the process EEG with second-generation NIRS. What's been useful for us recently, since December, is we have the ability, in fact, to show all these elements on the same screen, so we can look at those information combined with the oximetry findings. So that tells us the combination of those monitor. So when you use brain oximetry, what we know already is that the baseline value and also the intraoperative desaturation will correlate with outcome. We know that brain desaturation is possible. It's possible to correct it in the majority of time. We also know that brain desaturation is non-specific, and you need to figure out why is my patient having brain desaturation. The increase in the brain saturation correlates with the efficacy of your intervention. And finally, when you use brain oximetry, having transcranial Doppler and also the second-generation NIRS really helps to interpret at the bedside very rapidly this information. What's very important also is the use of bedside ultrasound. In the OR, we use transesophageal echocardiography. So this is just an example to show you how this is used in routine way. 76-year-old woman are doing aortic valve replacement. We're coming off bypass. There is ischemia on the ST. And the reason you have ischemia, in the left and the right lower corner, you see there's air. And the air goes in the right coronary artery. So this patient has RV dysfunction. The end-tidal CO2 is 23, and the brain saturation is 55, 52. Shortly after, we improve her cardiac function. We raise the perfusion pressure. You still have ischemia on the EKG. The end-tidal goes up. The brain saturation goes up. And finally, at the end, the ST change normalize, and then you end up with an improved RV function. The end-tidal CO2 and the brain saturation really goes up. And we're using 3D echo, so we have a 3D reconstruction. So you can see that despite the disappearance of the ST change, you still have some dysfunction in the inferior basal segment. And I'll show you why this was related to the air emboli. So basically, and at the end, finally, the end-tidal CO2 and the brain saturation goes up. So I often use brain saturation as, I would say, my non-invasive capnography when the patient is not intubated. But as your cardiac function improves, the brain saturation follows the same direction. So when you use brain oximetry, I always tell there's 5 elements that you need to evaluate. First is the arterial flow, but also the venous drainage of the brain. Both are very important in determining your brain saturation. The other elements is the oxygenation, your hemoglobin, your oxygen consumption, and your carbon dioxide. So about 2 years ago, we wrote this paper on the limitation of brain oximetry. And as you know, the way it works, you have emission of infrared light, and you have a detection, and then the superficial component is removed, so you have an information about 2 to 3 centimeters from the skin or the brain where you use it. What's important to realize is when you look at the relationship between the absorption coefficient and the wavelength, is that the absorption of the oxyhemoglobin is different than the absorption of the deoxyhemoglobin. So your brain saturation value will depend on the percentage of oxyhemoglobin divided by the oxy plus the deoxyhemoglobin. And with the second generation brain monitor, we have this information now. But we don't have the absolute value, we have the change over time. So basically what we're able to say is that the CHBI is basically the total hemoglobin, which is equal to the oxyhemoglobin, which is an index of the relative change in the oxyhemoglobin, plus the relative change in the deoxyhemoglobin. And I'll show you why this is relevant. So basically your brain saturation is equal to your change in the oxyhemoglobin plus or divided by the total change in hemoglobin. So this is a paper we wrote recently, was our preliminary experience using this monitor. And basically you have a normal value when when there's no change in your oxy and your deoxyhemoglobin, or sometimes you may have a normal value when all these elements are proportionally reduced. Brain desaturation will occur if basically you have an increase in your total hemoglobin from an increase in the venous, or a decrease in your total hemoglobin from a decrease in the total, or basically no change in the total hemoglobin, but an increase in the deoxyhemoglobin. I will just give you 2 examples of what this is, how this is useful. So, as you're coming on bypass, you often have brain desaturation. And the reason you have brain desaturation is that you have reduced cerebral blood flow. So what you will observe is a decrease in the oxy and a decrease in the total hemoglobin. However, in this patient, what happened is that we had a second unexpected decrease in brain saturation. However, at this time, what was happening is that it was the total hemoglobin and the deoxyhemoglobin that increased. And the reason was during clamping, there was accidental clamping of the superior vena cava. So that was increasing the amount of blood in the brain. And as you know, if you don't recognize this syndrome, this patient will present with facial edema, increased optic nerve length, and also on the transcranial Doppler, you can also see the reduction in your diastolic velocities. So in that situation, what you have is basically a brain desaturation associated with an increase in the total hemoglobin, because the reason of brain desaturation is basically venous congestion. Process EEG, and this is the device we've been using, basically provide you with 4 frontal EEG channels. You have what we call the patient state index, which gives you a number in relation to the electrical activity. And you have also the digital spectral array, which is quite useful when you want to detect what we call burst suppression. So the critical elements of this is that it's really, for us, a monitor of the depth of anesthesia and sedation. And the reason it's been developed was really to detect awareness or awakening, especially when we have paralyzed patients. However, this is very uncommon. It's less than 0.1%. What is more common, and we've seen this since we adopt this monitor, is excessive anesthesia and sedation, which occur almost in 1/3 of our patients undergoing cardiac surgery. It's an indirect brain monitor. I'll show you an example. It's also a vasoactive agent monitor, because if you have hypotension under anesthesia, you look at your cell line. And if your activity is significantly reduced, you know that your hypotension is secondary to the excessive sedation. We've reported our experience using this monitor last year, and basically we look at 300 patients, 150 patients before we start using it in 2017 and after 2017. And basically we found that in the operating room we were using much less vasoactive agents. We also observed that the amount of sedations and anesthetic gas was significantly reduced. But also in the ICU, we noticed that patients were arriving in the ICU with much less vasoactive support, and also the duration of intubation really went down since we started using this in the operating room. Transcranial Doppler can give you a lot of information on your cerebral blood flow, on your resistance index. You can pick up intracranial hypertension or venous congestion. I always tell when you have an abnormal Doppler signal from the brain, look at another signal, look at another site, because you cannot analyze the brain in isolation, especially with a Doppler signal. For instance, if you have aortic insufficiency, your pulsatility index will be increased, but it will also be abnormal if you interrogate another artery. For us, it's been very useful to detect or to realize the importance of emboli detection. Also, it can be used also for cerebral autoregulation, and we've been correlating it also with NIRS. So this is a transcranial Doppler signal, and this is the velocities typically on the middle cerebral artery, on the right and on the left, and this is how we get the signal. So I'll just concentrate on these two elements, which is the emboli detection and the relation with NIRS. So sometimes it can happen when you're coming off bypass that you'll have a lot of air in the heart. So this is a mid-esophageal long axis view, and you see air in the left atrium and the aorta. And you wonder, when you see this, what will happen next in those patients? So the emboli can be air, but it can also be thrombi, and also can be fat. And with the transcranial Doppler, you cannot necessarily make the difference which one it is. So let me give you an example. This is a patient, and often as we unclamp, we'll see these signals. We call it the high intensity or ITS signal. And what happened also, and the reason they are unstable, is that the air goes right into the right coronary artery. And that's why these patients become unstable, have ST changes. And when you look at the transgastric view, you can see, oh, we lose the signal. Sorry, oh, it's coming back, good. So, and you can see the emboli in the posterior basal region of the heart at the same time. This is an example of a patient before bypass. You can see the heart and the right ventricle contracting well. And after bypass, you can see the contraction of the heart is really reduced. And this is because this patient has a significant amount of air that goes into the RCA territory. Interestingly, in this patient, we had minimal change in brain saturation and also mixed venous O2. So until they are very unstable, you don't see changes in these parameters. This patient, in fact, had more than 1,000 number of hits on the left side. This is another example of patients coming off aortic valve replacements, a significant amount of air. You can see it on the transcranial Doppler. And what happened in those patients is if you take care of those in the ICU, well, you'll hear that they fibrillate many times. They have to be shocked. And also keep in mind that when we transfer those patients in the ICU, often air can be there residually. So when you start moving those patients, sometimes they can have a manifestation of air embolism. They can go in ventricular fibrillation, or they can go in shock after that. This patient, we had about 5,000 hits. So this has some prognostic value. This is a 26-year-old woman who came for a ROS procedure. We're unable to wean her from bypass. We had to go on ECMO. And unfortunately, when you use transcranial Doppler on ECMO and you initiate ECMO, there's no many hair filters on the ECMO. So these patients have a lot of emboli when we initiate ECMO. And in fact, indeed, this patient had more than 3,000 hits, and we were unable to wean her from ECMO, and she had to go for heart transplantation after a ROS procedure. There's now some device that's been used in the cardiology settings. This is a 40-year-old man who underwent an ASD closure, and it's a device which picks up the emboli or the clots, and the device is just positioned at the innominate artery. So this is an example of a patient. This patient had I could just pick up like 55 and 100 emboli. But when you look what was left on this device, when you remove them, you can see there were some elements. So there are studies actually going on how can we avoid these emboli during cardiological procedures. We've been looking at our experience using transcranial Doppler, and what we found is that definitively it is associated with difficult and complex separation from bypass. When you look at the different type of surgery, you can see that in valve surgery or in complex surgery, you have more hits. When you look at off-pump bypass, you have very little emboli because you have much less manipulation. Using multivariate logistic regression, we found that the number of emboli is an independent factor for difficult separation from bypass. So the key message I'd like to leave you is that whenever you have brain desaturation, it can be arterial, it can be reduction in blood flow, arterial blood flow, but also keep in mind, it can also be abnormal drainage, can be an issue. And with the second generation monitor, the real advantage is that we have the ability to detect this type of problem. If ever, and in such a situation, you'll have brain desaturation with an increase in the total hemoglobin. If ever you have hypoxia, anemia, or hyperventilation, the amount of blood will not necessarily increase in the brain. So you just have more deoxyhemoglobin compared to the oxyhemoglobin. And if ever a patient desaturates because he has increased brain activity, then you see it right away on your process EEG, you'll see increased activity. However, when you use this monitor and you have burst suppression, well, it can be because you have too much anesthesia, too much sedation, but then your brain saturation will be normal. However, if you have burst suppression with brain desaturation, that means that your cerebral circulation is compromised. Thank you for your attention.
Thank you very much for this excellent review. Questions from the audience, quickly? No, I have a quick question. Do you use regularly this multimodal monitoring outside the OR in patients with venous arterial ECMO specifically?
Yeah, so the brain saturation is routinely used in ECMO patient. We use not only brain, but you also somatic, because you can monitor the adequacy of perfusion of your limbs when you use this. Process EEG is used more and more often because we're seeing the same problem in the intensive care unit. We often have excessive sedation, which contributes to hemodynamic instability. Transcranial Doppler is not used as much in the ICU as a monitor, but we can ask to obtain information on transcranial Doppler, but not used as the routine monitor.
Okay. Thank you. Thank you very much.
All right, and we're going to move on to the next talk. It's Geert Meyfroidt from Belgium here, and he's going to talk on how I integrate it all. So after we've heard a lot of information, he's going to put it all together.
Thank you. Yeah, so how I integrate it all is, of course, quite a difficult talk because I will talk in an area where there's not that much evidence, and so I take the liberty to give a bit of my personal opinion on this and maybe a couple of maybe to some people provocative statements. I have some disclosures, but none of them are really directly related to this talk or will influence my talk. When it comes to neuromonitoring, the analogy with Plato's cave is always there, right? So we know that there's a lot of things going on in the brain, that there's inflammation, hypoperfusion, hypoxia, edema. And with our monitoring, we try to get some idea of what is going on inside the skull, but it's merely a reflection of the actual phenomena, and we will never be able to grasp it completely. And the expert group, or the consensus statement on multimodality neuromonitoring is actually quite interesting, because it first says neurocritical care depends in part on care for patient monitoring, and I think we all agree on that. And then there's the but. And I've always learned that when a sentence has two parts and there's a but, that the part before the but always gets devaluated. So because after the but comes, as yet there are little data on what processes are most important to monitor, how they should be monitored, and whether monitoring these processes is cost effective or impacts outcome. And still we do that. Still we do monitor and we react on the monitor. But of course, it's not the monitor that will change the outcome. It's how we integrate that, how we make decisions, how we treat that patient that will influence the outcome. And what is also interesting in this statement, I think, is that the information is not only used to treat that particular patient, but we also try to learn from it and maybe learn to treat future patients. And that, I think, is one important aspect of neuromonitoring that is present as well. So it's not a Voltairean approach that we just put in probes and then have fun and let the patient cure himself. No, we have made progress, slow progress over the past years in outcome. If you see what the outcome after TBI, for instance, looks like 30 years ago versus now in large series, you will see that we did make a benefit. But we have not found the magic bullet, the magic neuroprotective bullet. And actually, neurocritical care is hard work 24/7, while trying to optimize the balance between substrate delivery and substrate consumption. And actually, our neuromonitoring is aimed at that, and that might look trivial balancing, but it's actually quite complex because you have to do this 24/7, and that is why neuromonitoring can be so valuable. And there's a lot of modalities that we have to do that, and let's say that these are the 11 most frequent modalities that we would use for that. There's ICP, there's brain tissue oxygen, you've heard about it. We can monitor brain temperature, we can monitor regional cerebral blood flow, TCD, you just heard about jugular bulb, microdialysis, NIRS, and all sorts of EEG, scalp EEG, or deep EEG, or surface EEG modalities. And these techniques are indeed often combined, and if we combine more than one, then we have multimodality monitoring. As you can see, most combinations are combinations with ICP, and then one other modality, and most multimodality studies will use two measures. We'll combine ICP with something else, ICP with PBTO2, ICP with microdialysis, with EEG, with blood flow measurements. But then, as we say, monitoring will not change the outcome, interventions will. You will see that the studies, and you've had some of them presented already here, these are mostly small studies, hypothesis generating, with effect on intermediate outcomes, not on long-term outcomes. And so we kind of get stuck in these academic high-tech centers who produce these studies. This is very valuable work, but then the question remains, okay, now as a clinician in a hospital who treats TBI patients, what should I do now? What can I do with these studies or with this work to improve my patients? And when you think of neuromonitoring or any type of monitoring, there's this joke, of course, that is a good analogy of that. That is when a drunk guy who lost his key and is looking for them near a lamppost, and then a cop comes by and he says, "Can I help you?" "Yeah, I'm looking for my key." So they're looking together, and then the cop says, "Yeah, but did you actually lose it here?" "No, I lost it over there, but there was light over here, so that's where I looked." And that's what is often happening with neuromonitoring. We treat a patient on basis on the available signal, but we do not necessarily treat the actual problem that is going on. And that is actually quite important. So that is, if there's one lesson you want to have from this talk, if you apply monitoring, it should be there to ask to answer a specific question, or as Randy Chestnut would say, otherwise it's expensive voyeurism. And so you just try to ask yourself, what is my problem here? Do I have a problem with compliance? Do I have a mechanical problem in my brain? Is maybe ICP monitoring? Do I have a problem with perfusion, where also ICP monitoring can be a signal, but also TCD, maybe PBTO2 can help me. Is there a problem with substrate delivery here as well? PBTO2 microdialysis could be helpful, or is there pathological hyperactivity, and so maybe EEG probes or surface EEG, deep EEG could help here. And once I identified the part of physiology that is deranged, then I can start thinking about an appropriate treatment. And we all know that these treatments can be very risky. Some of them are actually very risky, like secondary DC or barbiturates are very high-risk treatments that you want to reserve for the most severe patients. And to proportionalize your treatment with the problem at hand, multimodality monitoring can definitely be helpful. And then thirdly, and importantly, of course, you also evaluate what your therapy is doing. Is there an effect of my therapy? Do I actually influence the signal? Do I make things better, or do I make them worse? If I make them worse, I have to take the step back. And that is the general framework where we apply monitoring. And if we think of monitoring, people always think of putting probes in the brain, but it's not only putting probes in the brain. For instance, monitoring the cardiac function if you do hemodynamic augmentation, knowing that a lot of our patients actually have either temporarily or have known cardiac dysfunction, and echocardiography or hemodynamic monitoring could also be part of your package. Assessing autoregulation, maybe if you monitor sedation, especially deep sedation, monitoring the depth of sedation in these patients is quite important. Radiology, so you should integrate your findings with radiology, with your CT findings. Labs, if you do osmolar therapy, we heard about hypertonic saline or mannitol. Labs are also part of this monitoring package, and you should you should be aware what am I monitoring here, what am I treating, what are the possible effects, but also what are the potential side effects of my therapy. And as such, there are some frameworks that could be useful for clinicians, maybe with not so much experience in treating these patients. For instance, the CIBIC guidelines, the Boost Bonanza protocols, and I will also talk a bit about computerized decision support. And I think most of you will be aware of the CIBIC guidelines now. The CIBIC guidelines who actually try to put therapies in different tiers according to their risk versus benefit, where they recommend that you try to use lower tier therapy if possible, and if the problem persists, that you then move to a higher tier therapy. Actually, I actually have one favorite frame in the CIBIC guidelines, and that's this frame. It's actually the most important frame. That is what you do between the tiers, the inter-tier. That is that you go to the patient, examine the patient, try to see whether there's something easily reversible, that you maybe repeat your imaging before moving to a next tier. So first define your problem, then move to therapy. And these CIBIC guidelines we have further conceptualized. This is a figure that I made together with Giuseppe Citerio. This is also conceptualization of this CIBIC guidelines, where you say, okay, do I have a problem with ICP alone? Do I have a problem with PBTO2 as well, or is there a combined problem? A bit based on what on the Boost study protocols, as you see here. Now, the CIBIC protocols can be criticized. They use thresholds. We will learn about thresholds also. Are they valuable or not? What is the risk balance of some of the interventions? Does hyperventilation really belong in tier 1? Do muscle relaxants really belong in tier 2? Some of the statements are vague in CIBIC because there's not enough evidence to give you a more specific guideline. They all assume a high resource environment, which maybe not everybody in this room has. And the outcome evidence for some of the recommended intervention is lacking, but also for the algorithm as a whole is lacking. But still, it is a suggestion for a safe and modern means of treating severe TBI for non-experts. It is voted in. It's something that 80% of the invited experts agreed upon. So it's a different level than you would have from a large clinical trial. Of course, it's a basis for improving your care, But it is not the best care, the standard of care, always the right way or the only way to treat these patients. Definitely not legally binding, and maybe it's not even the way that one of these experts would treat TBI care. It is not a substitute for your own thoughtful care and for your own clinical judgment. So actually what you need is an experienced clinician, of course, but maybe not everybody. I mean, we treat our patients 24/7, and in not all settings it's feasible to have 24/7 an experienced expert at the bedside. And maybe this is where artificial intelligence or computerized decision support could help. And this is a viewpoint by Claude Hemphill, who estimated that there's maybe 2,000 neurocritical care experts around the globe. Maybe that's a low estimate, but let's assume that it's 10,000 or 20,000. Even then, look at the number of stroke patients, TBI patients, such as epilepticus patients that we have to treat annually. There's no way that each of these patients will get the expert by the bedsides. And guidelines has led us to good outcomes, and they're good in a group of patients, but maybe not necessarily for a specific patient. And then we come back to the point of personalized medicine, which is maybe what we would try to obtain here. And so this graph is maybe a summary of that, where you say, okay, maybe there are settings where the outcomes are below standard, and guidelines could bring most centers to, let's say, what is the current center, but there's definitely people who can do better, the centers who do better, and maybe there would be a good way to get these expert level knowledge at the bedside. And for that, it's hypothesized that, for instance, computerized decision support could play a role, like Isicem Plus software designed in Cambridge. And there's been one randomized clinical trial, at least the Cogitate trial, where we randomized patient to a CPP recommendation by the software or a fixed CPP, and it was feasible using the software to get the CPP within this target in a bit less than 50% of monitoring time, without increasing the therapeutic intensity level, with higher CPPs in these patients, with a reduction in unacceptably low CPPs, and with a non-significant trend towards improved mortality. We in Leuven have developed our own software also, which is the Monte software, which includes prediction of future elevations of ICP within the next 30 minutes, a trend of ICP, information on cerebrovascular autoregulation, information on percentage of time where the ICP was in a zone of high dose with associated with worse outcome, and percentage of time above a certain predefined threshold. This software has been tested in the background already in one clinical trial and will now be prospectively tested in a future clinical trial. Now, to conclude, I don't really know, there's no answer to integrate it all for you. There's nothing that I can send you home with that will make you happy how to integrate it all. But the thresholds that we use might have oversimplified, and you will hear about that in the next talk, and maybe bioinformatics can come to the rescue here. It's all about treatments. It's a treatment that improves the outcome, balanced according to risk-benefit, and multimodality monitoring. We should see this also as a way to evaluate the response to therapy. And also for the personalized approach, I think we need trials. So in the end, we define a protocol, we define a personalized way of looking at it, and this should be tested, and if it works, it should be reproducible in many settings. And with that, I would like to conclude. Thank you.
Thanks a lot, Ted. Questions from the audience?
Thank you, Geert. Well, I think it was a very difficult topic. We need, I think, to move on, no, but thank you very much. And I will give the floor to Soojin Park from Columbia University, New York. To conclude this session, it's not only a matter of thresholds.
Also stay around, because after this we will have hopefully a couple of minutes for questions to the last three speakers.
Thank you. Oops. Okay. Thank you for your attention. This is a very informative and really well-organized session. I had said that this was impossible because there's diminishing evidence as we get sort of forward in this progression of talks, and I think I represent the far extreme. So I'm going to talk about beyond thresholds multimodality monitoring. So far, we've really talked about the background of individual modalities. You know, we all know why we're interested in neuromonitoring. These are patients with very fragile black box where time is brain, where time matters to detect secondary brain injury. We're interested in not just the single stream, and thresholds certainly can be helpful from an alarm setting scope of practice. We can't be at every bedside for every patient. But beyond threshold-based alarms, I want to talk about the context of the patient and how we can combine the information, zoom in, zoom out, depend upon visualization, and also how we can think about these individual modalities as features to be combined in data science to provide more of a personalized perfusion target. So very importantly, if you want to do anything beyond a single modality with a threshold, it's super important to get beyond that, the barrier of integrating the data and being able to then secondarily visualize it, and importantly, manipulate it, interact with that data. There's a syndrome that you're probably familiar with, the paroxysmal sympathetic hyperactivity. It spans really any kind of neurological injury, including even neuromuscular disease, reversible and structural disease. And we see this, elevation in vital signs, whether it's temperature, heart rate, blood pressure, from a non-painful stimulus. And it can be associated with a secondary brain injury that can be silent if you're not monitoring it. So it's diagnostically challenging because in a single shift, you might see it once, and very frequently it's mistaken for a mimic. Pain, agitation, even sepsis if you're not paying attention to the combination, and it's a bedside response, it's a protocolized response to some vital sign. Some medication may be given, it may be reported at the end, but then not seen in aggregate as maybe this is a paroxysmal syndrome that's happening over a shift or over several shifts. So in isolation, an increase in a single vital sign may not be very specific, and frankly, it's not quite alarming in the true sense. You can see elevated heart rate certainly all the time. And if you're walking by a room and you see the top and several hours later you see the bottom, it may not jump out at you as being something very specific, like a sympathetic hyperactivity syndrome. But if you were to simply look at it in the reverse of 1/RR interval, which is heart rate, but looking at it not as the EKG, you clearly see that this is elevation and is very singular and very sudden. And you might be, importantly, being able to aggregate this with the bedside observation that this also has some clinical syndrome of diaphoresis and agitation, and there was no trigger, it happened very spontaneously. And if you were to annotate also the treatment, you might be able to then pass on to the next shift how you might treat this in the future, what medication actually worked. And then if you zoom out to beyond a single shift, you can see this is a pattern. So walking by the room, you don't see it. It's heart rate, it's a little bit elevated. You don't even notice there are a lot of other things that are alarming. But if you zoom out, you get information now out of data. And this is a single vital sign. If you were to put it in aggregate with the other vital signs, heart rate, blood pressure, respiratory rate, and maybe temperature, you could really even hone down to what are agitation or what's paroxysmal sympathetic hyperactivity. So then moving on beyond just like a threshold and looking at visualization, what are thresholds and why is it limiting? So if you were relying upon this threshold for brain tissue oxygenation and to go beneath it to be concerned for brain hypoxia, you would miss this very important phenomenon. This is a patient with unrecognized seizures. And as the seizures are happening, in most protocols, you see that if you have brain hypoxia, consider that one of the things in the differential is seizure. But what you actually see in experimental models of seizure is that actually you have an increase in blood flow to the area, and then you eventually burn out, and you might see a drop in bold MRI with oxygen, but you could also see that in an RCBF. So in this patient, you would have missed completely that this is an indication of seizure because it never went below the threshold. However, you see this increase in ppTO2, which perhaps could be related to an increase in blood flow. And in this study, this is an aggregate of several patients, and they're normalized or anchored to the time of a depth EEG indicating a seizure onset, and you do see this increase of RCBF. So now what if you were to use streams of data in aggregate and not just use it for the information of the metabolic information of the brain tissue oxygenation, but trying to understand the situation or the physiology that's underlying it. So autoregulation is a sort of a reachable or touchable example of this. So this is a really nice study I like because they took advantage of, it's like a natural history, two neighboring institutions that had a very different approach to managing traumatic brain injury. And you see that on the y-axis here is the percentage of favorable outcome being high over here, and on the x-axis is a map over ICP slope. And so if your ICP is varying together with your mean arterial blood pressure, you're probably having a pressure-passive state, you're poorly autoregulating. And when you're in that poorly autoregulating pressure-passive state, the more likelihood of doing better is using the Uppsala ICP protocol, and certainly the CPP protocol, where you're driving your CPP high, you're going to do poorly because you're pressure passive. As a natural history study, right, you have the same kind of economic status of the country, you have the same kind of mixture of suburban, urban, where these hospitals are located, and the single thing that's different is the way that these protocols are built, favoring ICP versus CPP. And this just demonstrates what that slope looks like in a pressure passive versus a pressure active environment. And now if you were to look at your own monitoring at the bedside, how do you do that? So this is I would focus your attention on this one here, where on the x-axis is mean arterial pressure, and on the y-axis is ICP. And this suggests that the higher your ABP, the higher your ICP. So could your ABP be driving your ICP? Is this a pressure passive state? And you look down here, it's only 4 hours of data. And as this moves on, you have 4 hours more of data, and you can see how your actions sort of affect your physiology. And you can derive some hypotheses about what's happening, where is my patient in this sort of x-axis. And then as the technology, which is now quite old, had evolved, you can do this in a continuous computerized fashion. So you can look at the Pearson correlation coefficient between the MAP and ICP in little single units of time that are selected based on where the slow wave components of the ABP and ICP will be most informative for this relationship that's informative for autoregulation. You can understand what your status of autoregulation might be for that moment in time. And then averaging it over couple of minutes and having a moving time window, you can calculate exactly that MAP ICP plot, that scatter plot, for isolated periods of time. As we know, physiology changes with disease and time, and you can map it temporally and make it be a monitor in and of itself. And this turns out to be more informative or more associated with mortality than even something like cerebral perfusion pressure or arterial blood pressure. And if you were to even rely a little bit more, here I'll describe what's going on over here. Let me press that. Is that here on the x-axis, you have bins of CPP. And again, these are bins of CPP over a period of time that you select. And on the y-axis is that index. The Pearson correlation coefficient goes from +1 to -1. And if you have a positive relationship, right, between the arterial blood pressure and the ICP, that's bad, you're pressure passive, poorly autoregulating, and you're going to be on the high range. And you can see this U-shaped curve, where on the high range of PRX, or this index, you're sort of in an undesirable zone. And so for this unit of time, where you took this data and you mapped it out over bins of CPP, you could propose to see that these are your ideal or optimal bins of CPP for this patient for this accumulated period of time that you have selected. The last speaker mentioned the Cogitate trial, and that's actually what is defined as the optimal CPP, or CPP opt. So one study we did was we looked retrospectively at a large group of subarachnoid hemorrhage patients, and we found that right before delayed cerebral ischemia, you found that not that your MAP or your CPP was very different between the groups of patients who had the DCI, the delayed cerebral ischemia, or not, but rather it was this informative, individualized threshold. If you have ability to calculate your optimal CPP, what was your actual CPP at that moment? Was it below what your optimal should be in that left-hand wing, or was it above your CPP opt on that right-hand wing? And where you are in relation to your calculated optimal was very informative. And so we found that it was the group that had the group that was about to have DCI beforehand, even 3 hours, even the day before, you could see that this delta, this actual CPP, was below where you should have been. And interestingly, the most important thing is between these two groups, they were similar. They had the same kind of severity, but what was different was that the rate of patients who had a CPP actual that was below what optimal was calculated to be had higher rates of infection. And if they were infected, if their MAPs are normal, their CPPs are normal, and you're going by a universal goal, it's quite easy to imagine you're going to miss these insensible losses, not realize your patient's not euvolemic and is actually hypovolemic and is likely to suffer from underperfusion and have delayed cerebral ischemia. Another study we did with a larger group of subarachnoid hemorrhage patients is to look at brain tissue hypoxia in relation to your CPP opt. And what's interesting about this is that if you look on this bottom piece, there's this other graph that goes over here. On the lower end, when everything is normalized to your optimal CPP, and you look at your actual CPP, you can suffer from brain tissue hypoxia. That's actually very expected. We're not surprised by that. Interestingly, on the upper hand, there's no information gain from the brain tissue oxygenation. And most interestingly, when you're below your optimal CPP, your autoregulation is actually worse. And yet when you're above your optimal CPP, your autoregulation is not affected. That was a surprising finding. So now we talked about the patients who are under-perfused, if you will. Your CPP actual is below your optimal CPP. But now what about the other side? So people know about PRESS, about too much perfusion, hyperperfusion. If you're passively perfusing, you have run the risk of cerebral edema, increased ICP. So in these patients of subarachnoid hemorrhage, where we calculated your optimal CPP and where your actual CPP were, and then looked at every minute of EEG, continuous EEG, all these 173 patients had continuous EEG, and we scored every minute for if you had a seizure or if you had an ictal-interictal continua signal. And we found that when your CPP, your delta CPP was above your optimal, you were more likely to have seizures, you're more likely to have ictal-interictal continua. That is PRESS, right? PRESS is edema, seizure, etc. And so we don't often image these patients, and they just present as a phenotype of having a neurological deficit. But a neurological deficit in this kind of patient could be they're having ischemia or they're having hyperemia, having PRESS. And I'll go back one. Interestingly, we looked at the patients who were under the delta, and now we're looking at the patients who have supra-delta, right? They're supra-optimal. They actually had a longer length of stay, not surprising if they're having seizures and maybe some mental status changes from a hyperemia. But interestingly, those are the same patients who ended up going home or going to acute rehab as opposed to a skilled nursing facility, meaning that they were functionally better. So this is a temporary setback. And I think one conclusion you could make is that the closer you are to that optimal CPP could be better for you in a subarachnoid hemorrhage, but certainly if you had to choose one, you would choose to be higher. And then finally, going into sort of the Star Trek future kind of thing, if you have these multimodality monitors placed for a patient who has a poor exam, maybe it's a fluctuating exam, maybe needs to be sedated for other reasons, you don't know when you're going to be able to detect DCI because you don't have a great exam to follow, and you place one of these monitors, you can actually take this information in a unimodal way and make it feature extraction. So you can extract information about their autoregulation state by calculating that index of autoregulation. You can look at just the values of brain tissue oxygen, the values of ICP, and put it together. And this is an angle analysis. So basically, imagine these vectors. These straight lines are vectors. They're sort of theoretical. And so if you were to plot all the lines of that data set of that group of patients in a straight line and fit a line to what you call it, really well fit, that's probably a good model for that behavior of that group of patients. So now imagine it's not a line, but it's a vector and it's sort of a curvy line. It's mapped in multiple points in space. So it's not a line, but it is certainly a pattern or a trajectory of how that patient is accumulating information with each minute. And if you look at the groups of the red and the green, One group is the vector of all of the patients who ended up having DCI, and the other one is the red, and the other one is the group of patients who didn't. And as a single patient accumulates data minute by minute, and you're integrating all of those streams of data, you can see the angle difference between that patient, the unknown patient, not included in those two groups, and the distance of that patient to all of those similar data points of patients who had the outcome or who didn't. And that difference or that angle, if you're closer to one, predicts that you're going to be more likely to develop DCI. So this is a fully computerized, automatic thing that can happen as you're generating data, if you're able to integrate it and plug it into a pretty straightforward calculation that could be done in the backside so that it can give you some clinical decision support. So in summary, neuromonitors, I think, are way valuable beyond simply the threshold base, and you should look at trends over time and not be comforted by the fact that a number is just normal. The integration and annotation is really here. It's available if you value the output and the information you can get out of the data. And then, so this idea of nowcasting. So this is a term that I learned from Michael Pinsky, where as opposed to forecasting, there's a lot of value to trying to predict things, prognosticate, but there's also a lot of value in patients who don't have a great exam and where time is brain, we're nowcasting, understanding, I call it a situational monitor, what's happening in that brain right now and how can we mine that data for information.
Thank you very much.
Thank you very much, Soojin. I think we have maybe 2 minutes for questions, quick questions from the audience. I recall you that tomorrow, I think tomorrow morning, there will be discussion about artificial intelligence to predict coma and in neurological conditions. So this presentation opens this issue. Yes, David, please.
I haven't got a microphone, so I'll shout. But in your last but one slide, when you're looking at the t-test for concordance with DCI minus, DCI plus, the graphs you showed suggested more variance in the DCI minus versus DCI plus. Can you use summary measures of complexity like a Hurst exponent or something to describe those?
That's a very good point, and we do use things like variability in our feature engineering, so we try all the things, but our lab really relies upon domain-driven feature engineering, like you're saying, versus more data-driven. So in AI, and this is probably a discussion for tomorrow too, you could just throw all the data points into a computer and just say, find a pattern. But that doesn't end up being very explainable. But we're all very knowledgeable. We take care of these patients. We understand there are certain things like variability, like complexity, that really tracks very well with health and disease. And so we can leverage that domain knowledge and translate into now how am I going to featureize the single modality or multiple modalities together to give me that information that I'm trying to gain. So absolutely. Yeah.
Thank you. All right. Thank you very much, everyone.